terms of eyes, the periorbital area is a wonderful, almost chronological barometer of aesthetic changes within a patient's face. And the sort of things that we tend to see is skin laxity, and this will manifest itself in hooding, where a patient will tell you, I can't see my upper eyelid, or if I put on some eyeshadow, I can't see where it goes. So hooding comes as a consequence of a couple of things. Obviously skin laxity itself is one, but the second thing that tends to happen, I suppose, is that we get gravity bringing down the muscles of the frontalis and the eyebrow, so we can get a lateral brow ptosis. The other things that we need to look at in that area is hypertrophic orbicularis oculi, and to an extent the laser resurfacing by skin tightening can almost treat this as well. Instead of Anne having fat pads underneath her eyes here, what you can actually see is she's got some fat atrophy, and this has given rise to tear troughs, and as a consequence of that we may even fill this with some, I prefer hyaluronic acid, tend to go all the way sort of below the orbicularis muscle when I'm doing it, onto the level of the supraperiosteum, and place it there. And I find that after 2 or 3 treatments that the patient in some ways has built up probably enough collagen themselves that the problem of the tear troughs tends to disappear. There's been a lot of problems in Europe with products being put in there that shouldn't have been put in there, and particularly Merz has had a product recently that was pulled that I was very adverse to using myself until it had been used by more people. But certainly hyaluronic acid, particularly Restylane, probably Juvederm as well, is very, very safe in that area. So we know clinically also the photo-age skin tends to be more wrinkly, blotchy, and even leathery around the eyes. And eyelid laxity in some patients can cause ectropion or even entropion. And we can even get epiphoria, or laxity of the medial or the lateral canthal tendril. And there's not, or there has been, I suppose, until now, a variety of dermatological treatments available, such as dermabrasion, maybe even botulinum toxin, radiofrequency. But I have found that certainly fractionalized resurfacing is a wonderful either adjunct to blepharoplasty, surgical blepharoplasty, or else even that it can be used as a standalone treatment, particularly in patients who have got some level of herniation of the infraorbital fat pad. The tightening of the skin is enough almost to cause an effect. And I find we get 2 different effects. One almost immediately, particularly if you do a double pass, you'll see the skin tightening underneath the eyes. Now, within a period of a week or 2 also, I find that we get also delayed tightening. I think it works probably through myofibrils, and as new collagen is produced, I often check patients at 3 months, 6 months and 9 months, and it's quite obvious the difference in terms of infraorbital fat pads, how they have retracted. In some cases they're almost gone. If this patient had infraorbital fat pads, I find that sort of, when I press on them to cause the herniation, if they run very far laterally in terms of the sort of the little sort of line in the nimbuscus area, that they probably are more suitable for surgical blepharoplasty. If they just run to the mid-pupillary line or a little beyond, then the fractionalized laser tends to give a nice effect, and also can cause a little lift within the eyebrow itself. I tend also to use Botox in association with this, and probably Anne has got a family at home, and she knows well that if you're ironing a shirt, you're probably better off straightening it out first on the table. It makes it much easier to iron, and it's pretty much the same with us when we're doing eyes. If you have got a lot of wrinkles within the skin, you have to follow obviously the laser to the lowest level to achieve the same effect. If you use some Botox and the lines tend to reduce, then as a consequence the laser is much easier to use. But I also find that the big benefit, obviously, is the fact that you're almost preserving your working plaster Paris. So it's almost like somebody had a broken leg and you are sort of putting in plaster Paris and allow it to heal. Then if you have Botox done 5 days or a week beforehand, then by the time that the laser resurfacing is done, you'll get a much better effect because it's going to preserve your work, because the Botox or Dysport, as in our instance, probably won't wear off for another 4 to 6 months. Sometimes with patients, it's good to make them aware just how red they can get. Now I have 2 different levels of photographs here. That's probably closer to the truth, but there's no harm in some ways showing a patient how on their diary, from immediately after, 8 hours afterwards, 1 day later, 3 days later, 5 days later, how go through this cyclical process where they get redder and redder erythema. So I think whenever you do that, it tends to not have a situation where patients going to get scared that sort of on day 3 what's happening here. So I think prevention of problems is always preferable. So if patients are prepped beforehand, then no potential problems from down the line. Sometimes they can sting for a second or 2, but the good anaesthetics will not cause any difficulty. I'll need to get another one for that. Sylvia may ask me a couple of questions, but that's about it, you know. Alright, have I patients one? Alright. Well done, hon. That's perfect for us. La 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 la. Huh? Yeah. Now, Ant's handling that quite well. So I'm going to take advantage and put things up to 175. I can put my density up to 3 as well. And see how we go now. Can you handle that all right? Thank you, okay. I'm done. You have to let me do the work on my neck. Open up your eyes, sir. Thank you.
Are you alright?
Stand very low, actually.
Inside now.
Look up, sir. Okay.
Are you alright? Just step with it?
Sorry, you finished anyway?
Okay.
Okay, thank you.
That's great.
I'm finished in just 2 or 3 minutes now. Okay. Thanks, Al.